Thank you. Thank you, ma'am, for the introduction. I would like to thank Lee sir for providing this platform to present. Uh, I will talk about the heated humidified high flow nasal cannula in unit. Uh, I hope the slides are moving. So, specific learning objectives of this talk would be about the introduction, and I will talk about the rationale of using the HFNC, basic anatomy of HFNC system, mechanism of action, indications, contraindications, and take-home messages. So, we know that the preterm births are the leading cause of death worldwide. It causes the survival has increased with the advances of invasive and non-invasive ventilation and suppressing therapies. And we know that invasive ventilation has various complications like barotrauma, volutrauma, biotrauma, and more. So there has been a shift of approach towards the gentle ventilation and less invasiveness. And hence came the concept of non-invasive ventilatory support, which can be divided into a constant airway pressure support or a variable airway pressure support. Amongst the constant airway support, there can be the use of nasal cannula, and which can be high flow nasal cannula or low flow nasal cannula. With constant airway pressure, there are CPAP devices which can provide continuous flow CPAP or variable flow CPAP. Amongst the continuous flow CPAP, it could be a conventional CPAP or a bubble CPAP. Amongst variable airway pressure devices, it could be NIPP, synchronized NIPP, or nasal HFO, or nasal BiPAP. So we know that the CPAP and NIPP are well-established modes of respiratory support in preterm newborns. These reduce extubation failure. These are effective alternate to intubation and mechanical ventilation at birth for preterm infants with RDS. So why do we need triple HFNC over CPAP? Because we know that CPAP has a bulky interface and interferes with the bonding. It causes discomfort to the patient, can result in nasal trauma, and can cause CPAP belly. And more skill is required for the handling of CPAP. So in CPAP, there is a difficulty to carry out PMC, non-nutritive searching, neurodevelopmental intervention, and it also results in discomfort to the patient nurses. And hence, efficiency is a preferred mode by the parent.
Hello. Hello.
Yes, ma'am.
Abhijeet, I'm sorry to interrupt. Please, the audio is not very clear. Can you be a little louder, or maybe you can use earphones? It's
Yes,
not
ma'am, I'm
very...
using the earphone. Is it not clear yet?
Okay, maybe then you can be a little more loud.
Yes, ma'am. So, what is HFNC? It is a non-invasive respiratory support, heated humidified high flow nasal cannula. There is no universally accepted definition for the high flow. Usually, we consider it as more than 2 liters per minute. Some definitions are based on the minute ventilation, and others are based on the peak inspiratory flow. But usually, we consider high flow devices to be more than 2 liters per minute. So, what is the rationale? With the high flow, it causes increased FiO2 and decreased levels of carbon dioxide. And with the high velocity of the gases in the high flow, it causes the increased penetrance of the oxygen. And then it is an open system and hence causes the leakage of gas around the cannula, and there is no advertent extra pressure develop. And with humidification, there is decreased desiccation of the respiratory mucosa. I will talk about these concepts more in detail. So the basic anatomy is there is a flow meter or flow generator device, and there is an air and blender source should be there, which is connected to the humidifier and which is filled with the sterile water reservoir, and this in turn is connected to the heated inspiratory circuit, uh, which is attached to the nasal cannula of the high flow device. Compared to the CPAP, we can see that there is a single limb circuit. Inspiratory limb is only present, and it is an open system. There is in CPAP, there is an expiratory limb connected by a Y piece, and then which leads to the closed limb circuit. And we can see the nasal pond sizes are also small in the HFNC. There is larger in the CPAP. So various nasal cannulas which can be used for the ramp cannula. Then there is a tissue speckle short binasal cannula. Then this is the trager nasal mask, and this is the optical cannula which we commonly use for our. So the basic anatomy is nasal cannula of efficiency is uh, it is a flexi tube designed to minimize the condensation. Then it is skin proof, we know that, and this is the connector which can be snugly fit in. Then this is the prong size, prongs, soft ergonomic prong, minimize the risk of septic damage. For the size selection, we can have four groups: mature, neonatal, infant, and pediatric. Maximum flow rate which can be given is the most commonly used are in ICU or premature and neonatal, and we can give a maximum flow rate of 8 liters per minute. So selecting the correct cannula size is very important, because if the nasal cannula is incorrect of size, then it can lead to high descending pressures and pulmonary barotrauma. And if the size is appropriate, then this also avoids the respiratory resistance. Various commercially available devices are there in the market. Most commonly used in our NICO is Airvo 2 HFNC system. It is a company from New Zealand. It's turbine based and has a humidifier and oxygen source needed. So this is the flow HFNC system. It is a high efficiency hollow fiber cartridge humidification system. As you can see, this is the cartridge, and the air flows through this, and there is a circulating water which causes the humidification. It is a disposable and single use. Earlier it was withdrawn because of the risk of bacterial contamination, but now it has been reintroduced in the market. Other devices comfort flow efficiency that Teleflex. It has a high relative humidity and has similar efficiency that of airborne. Then this is the DAISY indigenous CPAP which we can use. We need the oxygen gas blender, and from there it is connected to the humidifier, and from this the inspiratory circuit is attached to the.
Hello.
Yes, ma'am. Hello.
Sorry to interrupt. Abhijeet, you please take care of the audio. The voice is not coming clearly and it's not very audible.
Yes,
Please to correct it.
yes, ma'am. Just.
सर अगर हेडफोन लगाया तो उसको हटा दीजिए तो क्लियर हो जाएगी सर.
हाँ sir, just 1 minute, I'll log it from another device because I think some issue with it.
Recording in progress.
Hello, ma'am, am I audible now?
Yes, much better now.
Yes, ma'am. Sorry. So the common, I was talking about the indigenous HFNC system. So it comprises of a gas blender, then we have a humidification chamber along with a humidifier, and then it is connected to the inspiratory limb, and which in turn is connected to the nasal cannula to the patient interface. Mechanism of action. So the main one of the major mechanisms of HFNCs is that it causes the washout of the nasopharyngeal dead space. It causes inspiratory resistance reduction, and it causes the improved pulmonary compliance and conduction by the humidified air. It reduces the metabolic work associated with the conditioning of the gases and causes improved pulmonary recruitment by positive pressure distension, by positive descending pressure. So which overall helps in reduction of the work of breathing. So how does it help in an anatomical dead space washout? So ideally, we should use a cannula size which should not be more than 50% of the nearest inner diameter. It causes the flushing of the carbon dioxide for the nasopharynx and mouth. Initially, when the baby is not on respiratory support, what happens is that once the baby expirates, there is accumulation of carbon dioxide in the nasopharynx. So this, and next time the baby breathes, it rebreathes the carbon dioxide from the nasopharynx because of the dead space. So what HFNC does, that is, it causes the inflow of fresh gas in the nasopharynx and flushes the carbon dioxide out from the nasopharynx and the mouth, and hence causes the decreased rebreathing of the carbon dioxide. So this is how the HFNC works. We can see that with the expiration, it is getting red, so there is accumulation of the carbon dioxide in case of unassisted breathing. But once we start giving the HFNC, then it causes the removal of the carbon dioxide and there is more accumulation of the oxygen. It also causes a reduced inspiratory resistance and air entrainment, and because we know that the nasal nostrils and nasal passage provide the highest resistance, So high velocity bypasses the nasal resistance and helps in decreasing the work of breathing. It also causes decreased entrainment of the ambient air. So when we use a normal low flow nasal cannula, so we can see that oxygen and air both are entering via nostrils into the lungs, but with HFNC there is less entrainment of the room air and more oxygen delivery. And with the use of the conditioned gases, there is better mucociliary clearance. There is better airway conductance because the desiccation of the mucosa is less, and also with heating of 34 to 37 degrees and relative humidity more than 96%, there is less insensible loss because some water would have been lost in humidification of the gas in the trachea. So that water loss is not there, and also the metabolic cost of heating the gas is also reduced because the air is already heated and humidified. Talking more about the nasal cannula diameter, we should always use the correct prong size, approximately it should always be less than 50% of the diameter of the nares, and preferably it should be between 25 to 30%. There must be leak around the nasal prongs, and the leak is very important as there is no expiratory limb on the HHFNC circuit. The distending pressure is provided by HHFNC. It is dynamic in nature and depends on the phase of the respiratory cycle. So the pressure delivery depends on the reduction. So the positive pharyngeal pressure, it depends on the reduction in the dynamic inspiratory airway resistance and splinting of the airways. And the level of PEEP generated by the HHFNC is lower than that of the CPAP for the same rates. And also it is affected by the flow rate, mouth opening, nasal cannula size, and measurement site where the pressures are being measured, also on the gestational age and the weight of the baby. So this is a scatter plot showing the nasopharyngeal and expiratory pressures and with relation to the flow weight adjusted flow rates. So we can see that with an initial 6 liters of flow, the relationship is linear, but beyond that, the flow varies largely, and so does the pressures. With the CPAP, there is more of nasal septal injury, and which can be appreciated. But with HFNC, the babies are more comfortable, and there is less nasal septum trauma. For the initiation of HFNC, we should start the flow at 2 liters per kg per minute. That is, we can start at 4 liters per minute. Then FiO2 starting could be 30 to 40%, and we have to target the SpO2s and titrate accordingly. The humidification, relative humidity should be around 100%, and temperature should be between 34 to 37 degrees. To escalate, the flow rate in increments of 1 liter per minute should be used. It should be guided based on the tachypnea, retractions, or work of breathing, and it can be increased maximum up to 8 liters, and beyond which we need to consider for CPAP and NIPPV. In terms of monitoring, the babies on HHFNC require comprehensive monitoring. Respiratory monitoring should include respiratory rate, heart rate, chest retractions, chest indrawing. Objective scoring such as Downey's or Silverman can be used. And we should also vigilantly monitor the hemodynamic parameters. And we should always remember to place an OG tube and keep it open. To define the failure of HHFNC, if there is a persistent requirement of FiO2 more than 40%, or if there is increased work of breathing, there is respiratory acidosis, that is pH less than 7.2 or PCO2 more than 60 millimeters of mercury, and there is recurrent apnea, then in those cases, we should consider a CPAP or an IPP or even a mechanical ventilation. To wean from the HHFNC, we should consider weaning once the infant is stable for 12 to 24 hours, and we should decrease the support every 12 to 24 hours. First, FiO2 is weaned, and then the flow rates are decreased. And the weaning should always be guided by the work of breathing and the oxygen requirement. So to summarize, we can wean the baby first FiO2 to less than 30%, and then flow rate should be decreased to 2 liters per minute, and thereafter we can discontinue. So what are the indications for the HHFNC? It is mainly used for post-extubation support in the preterm infants and weaning from the CPAP. as a bridge therapy transition to room air. It can be used as an alternative to CPAP in stable preterm infants with nasal trauma, but for better nursing care, for better mother-infant bonding, kangaroo care, and oral feeding. And it has also been used in the apnea of prematurity. So, did evidence about the post-extubation. So this was a Cochrane review in 2016, high flow nasal cannula for respiratory support in preterm infants. So there were total 6 studies and it involved 934 units. And they found out that there was similar rates of treatment failure and reintubation rate. The subgroup analysis showed that the 28 to 30 weeks babies benefited the more, and the risk reduction, relative risk was 0.8 for the treatment failure and 0.51 for the reintubation. So, but then we have another meta-analysis. This was in 2019, a high flow nasal cannula versus the nasal continuous positive airway pressure for respiratory support in preterm infants. So it involved the 21 RCTs and total of 2,886 units. And they found out that following extubation, CPAP had fewer treatment failures compared to the HHFNC. But then again, we know that CPAP had a significantly increased rates of nasal trauma and pneumothorax. Again, in 2020, this was a meta-analysis. High flow nasal cannula versus post-extubation respiratory support strategy in preterm infants, a systemic review and meta-analysis. So they reviewed 10 articles for the systemic review and 4 for the meta-analysis. And they found out that HHFNC is not inferior to CPAP following post-extubation following post-extubation respiratory support in preterm newborns with gestational age 32 weeks or less and greater than 28 weeks. There was less evidence for the use in the babies with less than 26 weeks of gestational age. And they, as we know that they also found out lower nasal trauma. And so we can conclude that because the risk of it is not inferior to CPAP in post-extubation, and also the risk of nasal trauma is higher with the CPAP group. So HHFNC can be used safely and efficiently as a primary mode post-extubation. Then with regards to the primary support, this was a landmark trial in published in 2015, a hipster trial. It was carried out in Australia and Norway. Total 564 infants were enrolled with the gestational age more than 28 weeks. And initially the trial was to involve the 750 infants, but it was stopped prematurely. And the primary outcome was treatment failure within the 72 hours. And what they found out that it was a treatment failure in HHFNC group was significantly higher, and the risk reference was a significant p-value with 0.001. And they also found that the median duration for the respiratory support requirement was higher with HHFNC group by 1 day. So this was also significant. But then another systemic review of high nasal flow cannula versus the continuous positive air pressure for primary support in preterm infants. So this was published in 2021. It saw the impact of the treatment failure within the 72 hours, and it was found that with HHFNC group, the relative risk of treatment failure was more by 34%. So, and again, they also found out the impact of reintubation within the 7 days. So they found that there was not much of a difference with respect to reintubation. So to summarize, HHFNC is a primary support. There is a significantly higher risk of treatment failure using the HHFNC compared to the CPAP, but this did not translate into a high risk of intubation in HFNC group. The rates of surfactant therapy sepsis were close to significantly lower in the HFNC group, and also considering the risk for the higher nasal trauma with the CPAP group, we can propose that HFNC can be used as a primary respiratory support in the preterm infants. About weaning, there are conflicting evidence from the randomized control trials because of the fewer patient enrollment, prolonged versus shorter oxygen therapy duration, and prolonged versus short hospital stay. And it was found that there was a slightly longer duration of hospital stay and a short and longer duration of oxygen therapy. So it may be viewed as an alternative to CPAP in those infants who continue to require non-invasive support. Then this was one of the recent articles, weaning strategies for withdrawal of non-invasive respiratory support applying continuous positive pressure continuous positive airway pressure in preterm infants. So it involved the 15 trials, and they found out that they actually considered 3 strategies for weaning: sudden weaning, then gradual weaning, and then interval weaning. With sudden weaning, they suddenly stopped the respiratory support. With gradual weaning, they tapered the respiratory support slowly, and with interval weaning, they would give specific time intervals such as 12 to 24 hours off and continue the intermittent respiratory support. And what they found out that with the step down strategy to the nasal cannula resulted in 3 weeks of reduction in the postmenstrual age at successful weaning from the CPAP. But it was associated with significantly longer duration of oxygen therapy by almost 8 days. And also they found out that with interval weaning, there was not much difference. So where does the HFNC stand with respect to primary support? It can be used as a modality for the primary support in babies with RDS or apnea of prematurity. And in terms of weaning, it can be used immediately post extubation or can be used as a gradual weaning method following CPAP. What are the potential complications of HFNC? It causes high advertent pressure delivery. It can lead to traumatic air dissection, scalp emphysema, pneumoorbitis, pneumocephalus, aerophagia, and epistaxis. We can decrease the complications by always keeping in our mind that choosing the appropriate nasal cannula size, then demonstrating adequate air leak between the prongs and the nares, and using the lowest possible clinically effective flow rates. To conclude, we should use only heated and humidified systems, as Grisar have always stressed that we should always get the heated and humidified air. And the open system, leakage of gas around the nares is a vital feature for the safety in babies with HFNC, because if we use the higher, if we do not use the open system and use the larger bore diameter of the nasal cannula, then it can lead to pneumothorax and inadvertent pressure generation. Then post-extubation support in preterm infants, it can be used as a primary modality and also weaning from the CPAP. And then we should always try to titrate FiO2 first and then the flow rate. HFNC, we know that it provides the ease of nursing care, has better tolerability with the infants, and also has a fewer side effects. Then we should always monitor. Close clinical surveillance should be done to detect the signs of failure such as acidosis or increased risk of breathing, hypoxemia, and switch the mode accordingly. Thank you.